Hello, this is Dr. Bhomik. Today I'm going to complete the second part of my lecture, the management of hypothalamic pituitary adrenal axis suppression. This is part 2, and this part is actually more important because here you will learn how do we decrease from the stress dose and a high dose to the maintenance dose and ultimately discontinue them. And as I have mentioned before, that this is one that I have compiled by studying many information from the different sources, including the textbook. And as I said in my first part of the lecture, that there is no complete uniformity of the opinion, but I do believe that what I am going to tell you, this is conservative, and the people do differently, and you will not go wrong by using this conservative management of suppression. So first question now comes in: how much steroid actually suppresses the adrenal gland? How much steroid one need to take? And this slide I have in my first lecture, and this is actually a good statement, and I am going to read it to you. As a general rule, any patient who has received pharmacological or supraphysiological doses of steroid and which is capable of elevating the plasma concentration throughout the day for 2 to 3 weeks should be suspected to have adrenal suppression and until proven otherwise. That means it should be assumed their adrenal gland is suppressed because of the duration and the dose that you have used. Let's go back to the next slide. So what determines the degree of hypothalamic pituitary adrenal suppression? Obviously, this I have mentioned in my first lecture also. Dose and the duration, depending upon the dose and duration, and the potency of the steroid. Now, decadrone or dexamethasone is 25 to 30 times more potent than the cortisol or prednisone. So clearly, this will suppress the HPA axis much faster and quickly. And the route of administration, as I mentioned, oral versus IV. IV clearly suppresses faster, but I'm not quite sure that how important that you need to take that one into consideration. Then, so once the hypothalamic pituitary adrenal axis is suppressed, now the question is how long it takes for it to recover. So in general, it is believed that it may be, the axis may be suppressed for 3 months to 1 year. And so let's discuss now the recovery. This study has been done by doing the serial measurement of cortisol ACTH stimulation test, and it is quite a few institutions. This has been done. It is in 2000. earlier part or even the middle part of the 2000, and this is what the result that I am going to share from to you. So steroid withdrawal syndrome, and that will occur immediately after you withdraw steroid. So the plasma ACTH and cortisol will be low in first month after withdrawal. So some, not all of them, some of them will have steroid withdrawal syndrome, but the laboratory wise the cortisol level and ACTH level will be low. And if you give the ACTH exogenously or do the ACTH stimulation test, is clearly going to be subnormal. And what about between 2 to 5 months? Let's see whether we have made any headway here. Here the study has shown that there is increased ACTH in circadian pattern, and it almost returned to normal or normal in many cases. But that also should depend upon how long the steroid has been used and the dose dependent. However, in general, ACTH rhythmicity pattern will be back to normal or almost normal in most cases. Cortisol level is still going to be low, and if you give exogenous ACTH, or other words, do the ACTH stimulation test, more than likely it is going to be subnormal. So let's continue with that. What happened between 6 to 9 months? Well, the study has shown that there is significant recovery has occurred, and so you may have a normal ACTH and cortisol level, and then ACTH response to the stress may still be suboptimal in some case. How do we do that? Again, the ACTH stimulation test. You give exogenous ACTH IV and then see the response you would like to see, and I will mention to you the response that we like to see. But the response could be normal, but it still could be suboptimal. They are there, close, but not there yet. Then normal response usually observed by far most of the cases after 9 months. Okay, so what is the practical approach? And this is what, as an endocrinologist or a fellows, that you should remember, or I think that this is a very good statement, and that is, if the period of steroid cessation is more than 3 months and the patient does not have any cushingoid features, mark the word cushingoid feature, you can anticipate the adrenal insufficiency without giving the patient a stress dose. However, you should be ready in case if you see any symptom, then you should be ready to give. But for the majority of the regular illness and minor surgery, after 3 months, you may not need any stress dose. But again, this is a clinical decision, and this is also depends upon the type of illness and type of surgery you are dealing with. So Is there a clinical indicator that will tell you for sure the HPA axis is suppressed? Answer is yes, and that is a cushingoid obesity. If the person or the child has developed cushingoid phase, cushingoid obesity or central obesity with strive, no test is necessary. You know that this patient is significantly suppressed. So hypothalamic pituitary adrenal axis is significantly suppressed. And no question, you should give a stress dose for 9 months to 1 year unless you have really shown a normal cortisol response and ACTH level after ACTH stimulation test. But in general rule, if the patient cushingoid features persist and if it is even 7 months to 1 year, I will still give the stress dose. So these features is that important. So there is one thing I have mentioned in my last lecture, that when you stop steroid rather quickly, then two things happen. One is immediate, that's called a steroid withdrawal syndrome, and that occurs within 24 to 48 hours right here, and it occurs about 50 to 90% of the cases, and these patients complain of lack of appetite, nausea, myalgia, malaise, arthralgia, general feeling of not good, and that is your steroid withdrawal syndrome. However, that should not be confused with adrenal insufficiency, which is very dangerous, and it occurs about 24 hours to 1 year. So during the period of suppression, it could come anytime. And the incident, it is rare, but if do again, it is stress related. Whatever is the form of stress, from illness to surgery. And I have just outlined some of the prominent symptoms of adrenal insufficiency, and that's the nausea, vomiting, abdominal pain, fever, prostration, diarrhea, shock, and hypotension. So this is a very dangerous situation, and this is a medical emergency, and this need to be treated with IV stress dose of steroid right away. The ACTH stimulation test done a little bit differently in different institutions. There are places where they are doing the low dose ACTH stimulation test, but I'm going to stay with the standard ACTH stimulation test that I learned, and many people still use it, to keep the ACTH IV. IM can be given, but when somebody is doing the test, IV is the most preferred route. And you repeat the cortisol level at 30 minutes and 60 minutes. In some institution, they have done 90 and 120 minutes, and that's perfectly acceptable. What they like to show that yes, it has recovered, but the recovery is delayed. So it's not as prompt as you would like to see. So still it takes, there is lag behind. So it's kind of sluggish. So that's why 90 minutes and 120 minute sample will help you. And what is the normal response? Well, there are some places I saw 12.5, but 18 microgram is median, and 15 to 20, if you have the response up to that much of steroid cortisol, then it is good that body's response is adequate, and it has been correlated with major stress as well. So 15 to 20. So what is stress? Well, fever is a big stress, but it's usually 101 and above. Children with a low-grade fever, mild URI, will not have that much stress. So fever more than 103 is a major stress. So if the patient is running fever more than 103 degree Fahrenheit, then it is a major stressor. Vomiting and diarrhea. Diarrhea, you lose fluid. The vomiting, you cannot take the medicine straight dose by mouth. The combination of vomiting and diarrhea is a disaster. So in this case, if the patient is not close to the hospital, and the family should give IM injection of hydrocortisone, as I have discussed many a times in my congenital adrenal hyperplasia lecture, and also in Addisonian crisis as well. And surgical delta procedure, this all depends upon how big is the surgical procedure, but then again, if it is within first 3 months, it's probably a good idea to give some stress dose. However, URI, fever less than 100, ear infection, mild cold may not need a stress dose. So now I'm coming to the little bit information that might be helpful, and that's let me put all the slide together now here. So suppose the patient is going to have surgery and the patient is adrenal suppressed, either manifested by the test or the duration of stopping the steroid or by cushingoid features. So before surgery, one should give hydrocortisone, IM or IV, 5 to 10 times of the cortisol production rate, 12 hours or preferably 24 hours prior to the surgery. Now, this can be divided every 6 to 8 hours, and this is, I realize, is conservative. So you can give the dose, the amount that I told you, about 6 to 8 hours. Then hydrocortisone 50 milligram per meter square can be given by infusion during the surgery and the recovery period. During the surgery or recovery period. No infusion is necessary if the surgery is lasting for less than 1 hour. But I have seen some endocrinologists suggested that give hydrocortisone one dose, loading dose, IV before surgery. If the surgery is done by 2 hours, 2.5 hours, as soon as the patient comes to the recovery room, give another dose. You may not need infusion. Again, there will be different stroke for different folks. So different endocrinologists will probably do things a little bit differently. Now, once the surgery is complete, then reduce the dose by 50% on the first post-operative day, and 60% by second, and by third day it is 75% of the steroid you can reduce by third day of operation, and then you can come back to the maintenance dose. But if the patient is not on steroid, then you can stop it. Now let's come across a situation where the patient has been on high dose of steroid for certain disease or condition. So these are the few ways one can try to taper the dose. The one is to reduce the dose by 20 to 25% each week until a maintenance dose is achieved. That's one method. Or some people who like to rapidly come back, 2 to 5 milligram of prednisone every 3 to 7 days and come back to the physiological dose. Now, this is shake up the hypothalamic pituitary axis a little bit more. However, the problem with this one is that if you go that fast, the disease for which the steroid has been used might recur. So one need to take into consideration that for this condition steroid is no more necessary, then it will be a good way. But if you think that the disease might come back, then this will be a better way of doing it. And this is also acceptable. So taper the high dose as quickly as possible to 10 milligram of prednisone or equivalent to 40 milligram of cortisol. Then we have come pretty close to maintenance dose. Still it is more than maintenance dose, but after that you can reduce 10% every 4 weeks to the physiological dose. Longer period of time, physiological dose. So you have got all this way you can do it, but again I have seen it done differently by different endocrinologists. So once you have come to the maintenance dose, it is important. That's why you have got to be careful not to do it very fast. So the other way one we can do is that decrease the dose by half of the maintenance, like 2.5 milligram of prednisone daily, or decrease the dose to 50 milligram prednisolone per meter square every other day, or repeat AM cortisol after 4 to 6 weeks and see whether you are ready to discontinue the steroid. If AM cortisol is less than 10 microgram, then continue with your tapering and repeat the cortisol in 4 to 6 weeks to see that whether you have come to the level more than 10. However, what happens if you are on divided dose of steroid? There are some patients for their disease process, their steroid has been divided like 3 to 4 times a day. Best thing is to change the whole dose in one single milligram amount. So somebody has been on like 40 milligram in divided dose, make it 40 milligram daily and give it in the morning. And then you follow the protocol as I discussed in my previous slide. Now there is a group of endocrinologists, they actually believe that by tapering you may prolong the period of recovery. Now the question comes then to taper or not to taper. All right, let's look at the argument here. They say that stop the steroid therapy abruptly if the patient does not have any serious intercurrent illness, or the patient disease process is not going to come back, and the patient who is not cushingoid. Mark the word cushingoid. Okay? So if you fulfill these criteria, then you can stop the medication. However, also the reason is that tapering delays the recovery, which I mentioned before, and also it unnecessarily exposes the patient to the toxic dose of steroid, toxic side effect. And many people believe that tapering actually does not protect you against the stressed situation or vascular collapse. What they say that by the time this thing will happen, you probably have come to the physiological dose, and having that physiological dose, you may not take it that seriously once the stress comes. And so, well, the patient has been on a steroid, and so people may not pay that much attention. However, if the patient has been told and that this is very important, re-emphasized, then they will very quickly start with steroid stress dose. Well, this is the sum of the proposal. This is actually not mine, and I found out that this is very credible, but I'm sharing with you. So tapering does not protect you from stress or vascular collapse, and patient require stress for 9 months to 1 year regardless. They do believe, this group also believe, that we have to remember this patient is under this very vulnerable condition for 9 months to 1 year in terms of vascular collapse and steroid suppression syndrome, and therefore one need to be careful and give them stress dose between 9 months to 1 year. Thank you very much. Again, if the patient, I am concluding by saying, if the patient has cushingoid features, tapering or not tapering does not come into. You have to taper, and the patient will be assumed to have significant adrenal suppression until proven otherwise. Thank you very much.